Welcome to PaedsCrib, where we guide young minds to heal young lives through case-based discussions. I am Dr. Manyesane, a pediatrician based in East London. If you find value in our content, don't forget to subscribe, like, and share with peers. And make sure you hit the bell notification so you never miss an update. Let's dive in and grow together. Today, we're going to be talking about Reye Syndrome. So Reye Syndrome is very rare, but it is potentially fatal. It is defined as an acute non-inflammatory encephalopathy with fatty degenerative liver failure. So from that definition alone, you can deduce that Reye syndrome affects the brain and the liver. It causes brain dysfunction and liver dysfunction. It usually occurs after a viral illness, and the most studied viruses is influenza A and B and chickenpox. Of course, other viruses that cause upper respiratory tract infection and gastroenteritis can also cause Reye syndrome. There also has been an association with the use of aspirin during the viral illness, which triggered these children to present with Reye syndrome. As we all know that these infections, they share common symptoms, especially fever and headache, that we used to use aspirin to treat those. And now during the recovery of the infection after using the aspirin, these kids have been found to develop symptoms of Reye syndrome. So Reye syndrome can be safely defined as a post-infectious triad consisting of encephalopathy, which is brain dysfunction, liver degeneration, which is liver dysfunction, and elevated liver enzymes. Reye syndrome commonly occurs at the ages of less than 18 years, with a peak incidence between the ages of 4 to 12 years. It has been found to be the most common cause of secondary mitochondrial hepatopathy. Therefore, if it is secondary, it means that there are primary causes. For example, inborn errors of metabolism, especially those that affect fatty acid oxidation. And therefore, that tells us that in younger kids, especially those that are less than 5 years, who present with Reye syndrome or Reye-like symptoms, it is important to also consider inborn errors of metabolism as a cause. With the decreased use of aspirin in children, there has been a drastic decrease in the incidence of Reye syndrome. The exact cause of Reye syndrome is unknown, but it has been found to be precipitated in genetically susceptible individuals with an interaction of a viral infection like influenza A or B or chickenpox or varicella with the use of salicylate, meaning that for a child to develop Reye syndrome, this is a child who has a risk factor genetically with also an interaction of a viral infection, which then becomes treated with the use of aspirin. Then that will trigger this child to have Reye syndrome. As I've said, that the Reye syndrome will usually develop 3 or 5 days after the recovery of the infection. We have said that Reye syndrome is the most common cause of secondary mitochondrial hepatopathy. So please stay with me as I take you through the pathophysiology of Reye syndrome and explaining exactly what happens. So we said there's 2 organs affected in Reye syndrome, the brain and the liver. And the problem actually starts with the liver. Specifically the liver cells, hepatocytes, and specifically the mitochondria in the hepatocytes. So Reye syndrome is defined as mitochondrial hepatopathy. So it means there's a damage of the mitochondria inside the liver cells. So mitochondria is responsible for oxidative phosphorylation and fatty acid beta oxidation. And both these 2 processes are responsible for generating ATP. And ATP is needed to produce energy for the hepatocytes. So if there is no ATP production, it means there is no energy for the hepatocytes, and it means the hepatocytes will die. Now the question is, what is causing this mitochondrial hepatopathy? Let's look at the salicylates. Salicylates have been found to cause uncoupling of the oxidative phosphorylation. So it means they make that process inactive. And if that process is inactive, it means there will be no ATP production production and therefore no energy for the hepatocytes, and then they will die. There's no exact explanation as to what is the role of viruses in this mitochondrial dysfunction. Now, as the hepatocytes are dying and the liver is dying, as we know through filtering of blood, the liver is responsible for filtering toxins in the blood or detoxifying things that we don't need in our blood circulation. And one of those things, it's nitrogen containing substances like ammonia. So now if the liver is unable to detoxify ammonia, it means ammonia is going to accumulate in the blood circulation, and ammonia can cross the blood-brain barrier and go into the brain. And into the brain, it has been found to directly affect the astrocytes. It has been found to cause swelling of the astrocytes, and the exact mechanism is unknown. And as this ammonia accumulates and causes swelling of these astrocytes, it means the brain gets inflamed and it gets edematous, and these patients present with encephalopathy. And there are actually 5 stages of this encephalopathy. Please stay with me as I take you through the stages of encephalopathy in the following slides. There's 5 stages of encephalopathy caused by Reye syndrome. These stages are caused by the increasing edema, which leads to the raised intracranial pressure. Stage 1, these patients are usually sleepy or drowsy and they might be vomiting. Stage 2, they become stuporous, they have seizures with decorticate postures, but in this stage they still have pupillary response. Stage 3, they may be in coma, they have decerebrate postures now and they no longer have pupillary response. And stage 4, they are definitely in coma and they lose their dip tendon reflexes. And stage 5 is death. So the investigations that you would want to make sure you do in a patient with suspected Reye syndrome are mainly to look at the liver damage, mitochondrial damage, and complications. So firstly, you would want to do your bloods. You make sure you do your LFTs. These patients will have increased transaminases, that is your AST and your ALT, because of the hepatocyte damage. These patients will have a high ammonia serum levels, as we have said that one of the liver functions is to filter nitrogen containing toxins like ammonia. Now, because the liver is unable to do that, these patients will accumulate ammonia in the circulation. You would want to make sure you do your coagulation profile, your INR and PTT, as one of the functions of the liver is to synthesize clotting profiles 2, 7, 9, and 10. So these will be prolonged. You also want to make sure you do your blood glucose levels, as the liver is also responsible for storing glucose into glycogen, and if the liver is failing, it means these patients can have hypoglycemias. You also want to look at your electrolytes, specifically sodium, because if the cerebral edema is so severe, these patients, they can have syndrome of inappropriate ADH with a hyponatremia. Then you will also want to make sure you do your imaging just to assess the severity of the edema before you start treatment in these patients. On managing these patients, make sure you admit these patients in an ICU setting, as they might need ventilatory support. 2, you want to make sure you control the raised intracranial pressure by doing head elevation to 30 degrees. Give them mannitol or hypertonic saline infusion to decrease the cerebral swelling, and you might want to mechanically ventilate these patients and hyperventilate them a bit, as low CO2 causes cerebral vasoconstriction and decreases the perfusion to the brain and therefore decreases the cerebral edema. 3, you would want to make sure you monitor and correct any metabolic disturbances. Hypoglycemia, make sure you give them dextrose containing IV fluids if they are hypoglycemic. Make sure you correct hyponatremia, especially if it's severe, that is less than 125. And 4, you want to, or 5, you want to support the liver. If these patients, they have coagulopathy, you might want to start them on vitamin K and also give them FFPs. You might want to avoid any hepatotoxic medication on these patients. Then medication you can give them first steroids to decrease the cerebral swelling. You have to give these patients anticonvulsants, especially if they've had seizures. Control ammonia. You can give these patients lactulose, and in some cases they might actually need to be dialyzed to remove the ammonia from the blood. Respiratory support, as I've said, make sure they are on the hyperventilated side, and do make sure that you avoid aspirin in these patients. So that is how you would want to make sure you manage and you support a patient with Reye syndrome.